Good afternoon, everyone. Buonasera or buenas tardes. Today is our 20. I'm trying to count them because there are so many now. It's probably 24th lecture of our liver online imaging series. And today is even the most special day of our series because we are hosting one of the most accomplished, one of the most world-renowned surgeons, liver transplant surgeons. He's very well known. So I don't need to speak so much about him because he's very well known liver transplant surgeon. He's a clinical director of Thomas Starzl Transplantation Institute and the chief of Division of Transplantation in the Department of Surgery at the University of Pittsburgh Medical Center. He's also a professor in the Department of Surgery at University of Pittsburgh School of Medicine and a staff physician at Pittsburgh VA Medical Healthcare System. Prior to this, he was professor and also the director of liver transplant program at University of Minnesota. Dr. Humar received his medical degree from the University of Ottawa, from which he graduated magna cum laude and was a silver medalist of his class. After completing surgical residency at the University of Ottawa, Dr. Humar earned a research and clinical fellowship in transplant surgery at the University of Minnesota in 1997. Dr. Humar's clinical interests include adult abdominal transplants, including kidney, liver, pancreas, and bowel, pediatric transplants, living-related liver transplants, split liver transplants, complex hepatopancreaticobiliary surgery, total pancreatectomy uh, with O2 islet transplant for treatment of chronic pancreatitis. His research interests are partial liver transplants and studies of liver regeneration, clinical outcome studies in kidney, liver, and pancreas transplant, clinical outcomes in donors and recipients of living donor liver transplants, clinical studies, and the trial to promote tolerance after transplant. I mean, our time is really short and limited. Otherwise, I would have actually spent 2 hours maybe in introducing Dr. Abi Humar. And without further ado, I would ask Dr. Humar to start the lecture. His lecture today is going to be about basics of liver transplant and liver and living donor liver transplant. So it's very important for us as radiologists to completely understand what our colleagues from the surgical units are looking for. Otherwise, we will not be doing good job. So with that, I would like to ask Dr. Humar to start his lecture.
Thanks very much for that very kind introduction, Khaled, and thank you for the very kind invitation to speak to this group. It's my pleasure. So I'd like to spend the next 45 minutes or so talking about just a basic background of liver transplant with a special emphasis on live donor liver transplant and some of the surgical aspects and how they sort of interact with other specialties, including the radiology colleagues that we work with on a regular basis. I'll try to keep this mostly surgical and medical related and not to try to get too much into the radiologic aspects, which you're all better suited at than I am. So it's very appropriate that I'm giving this lecture here from Pittsburgh because many regard Pittsburgh to be the birthplace of liver transplantation. It's really regarded as one of the miracles of modern medicine because if you think about it, this is a field that really just started maybe about 35 years ago with the first real successful transplants being done in the early 80s to the present time where now it's really the established gold standard treatment and the definitive and sometimes the only treatment for anyone with end-stage liver disease, whether it's acute or chronic, in nature. And we now see results that are really quite good with 1 year survival, generally over 90%, 5 year survivals up to approaching about 80%, which is really quite remarkable given its really quite short history. And much of that credit goes to this gentleman right here. That's Dr. Thomas E. Starzl, who's often regarded as the father of transplantation, certainly man who spearheaded the development of liver transplantation, at least in the United States and worldwide, and led to the creation of the program here, and in fact trained many of the surgeons that went out throughout the world and established liver transplant programs all throughout the world. And he's the gentleman who this center is named after, the Starzl Transplant Institute. So liver transplantation, as I said, has become really very commonplace now. The number of diseases that we can potentially transplant is huge, and this is just some of the more common ones that we transplant. And remember, transplantation is applied to both the elderly as well as almost the newborn. So we transplant across the entire spectrum. The most common diseases that we transplant for are the non-cholestatic liver diseases that used to be hepatitis C at one point, and that has become less and less common and is now generally being replaced, at least in North America in the adult population, with diseases such as NASH. And then cholestatic liver diseases such as PSC and PBC. In children, biliary atresia is very common, and other common diseases are metabolic diseases in them, acute hepatic necrosis, and finally malignant neoplasms, which are becoming more and more commonplace. And as you know, all patients with cirrhosis really are at risk for developing malignant neoplasms. So just very briefly about the operative procedure, because it's good for you to understand a little bit about the operation and what it involves. So remember, this is an orthotopic procedure. Orthotopic meaning that the old diseased liver is removed and the new liver is placed in that same location. So as opposed to a kidney transplant, which is heterotopic, this is an orthotopic, whether this is done from a deceased donor or a live donor. Now remember, at least in the United States, and this is not the same throughout the world, but at least in the United States, the vast majority of transplants, liver transplants that are done, come from a deceased donor. And these are whole organ transplants, meaning that it's the entire liver that's transplanted. But regardless of the type of transplant, the liver transplant procedure can be divided up into really three main phases. One is the initial is the dissection phase. This is where you're essentially doing the work to remove the old diseased liver. And sometimes this can be the hardest part of the operation, because remember, these are patients with cirrhosis, portal hypertension, sometimes a large liver, sometimes small, but large spleen and enlarged veins. And so this can be a bloody part of the operation. The next part is what we call the enhepatic phase, and that's once we remove the old liver, so the patient is now enhepatic, meaning has no liver, and clamps are placed across the structures that will be used to reconnect the new liver. And these are essentially the inferior vena cava, the hepatic artery, the portal vein, and then the bile duct. And those are really the main anastomoses that go into place. And during this time, the anastomosis of the new liver begins, usually with the inferior vena cava, the portal vein, and then the hepatic artery subsequently, to reestablish vascular flow. And then finally, what's called the reperfusion phase, and that's where the vascular clamps are released and new blood the blood is reestablished to the donor liver. This is sometimes often the most critical time of the operation, because you create lots of conditions for cardiovascular and metabolic changes that can happen, and patient instability can happen at that time. And so this is a very crucial time. And once that happens, then the final anastomosis, which is the bile duct, is then done, which is biliary drainage, either to the bile duct itself of the recipient or to a loop of intestine, which is called a roux loop, and that's a hepatocogenostomy. And that's what the new liver looks like. This is a deceased donor transplant with the whole liver transplanted in there, and you can see the nice color and shiny appearance of a new healthy liver as compared to the cirrhotic liver that was in there before. Now, there's lots of variations as to how you can do the transplant and what you connect to, and all of those have their own little nuances. But just to talk a little bit about some of the variations of surgical technique, which I think would be important, especially from a radiologic standpoint, is in a deceased donor transplant, the standard way, and that was what I showed you before, is what's called a caval replacement, where you take the recipient's cava out and replace it with the cava that comes with the new liver. But that's called a caval replacement. But you can also do what's called a cavaplasty, a side-to-side cavaplasty, and in this you're actually preserving the cava of the recipient, which is this structure right here, and you're anastomosing the cava of the donor, which is this structure here, in a side-to-side manner that's here. And so the new liver sits on top of the cava of the recipient, and that's called a side-to-side cavaplasty. And the advantage of this is that you don't have to cross-clamp the entire inferior vena cava when you take the old liver out, and therefore venous return to the heart is preserved, and the patient maintains a better degree of hemodynamic stability. But this is important then to remember what sort of connection they have, especially when you're studying the outflow radiographically to get the anatomy correct. And this is another variation of that. This is called the standard piggyback operation, where the liver is essentially, new liver is essentially piggybacked onto the inferior vena cava of the recipient. So this is the inferior vena cava of the recipient. These are the three hepatic veins, the right, middle, and left. And these are opened up to create one large orifice, which then you anastomose to the suprahepatic cava of the donor cava that comes with the liver. And this is what it looks like on the side section. You can see that the liver is now piggybacked onto the cava of the recipient. And again, the advantage of this is you now don't have to put a clamp on the recipient's inferior vena cava at all, and that allows you to maintain venous return during that anhepatic phase and maintain a better degree of hemodynamic stability in the patient. So again, important for you to know, especially when you're studying outflow, as to what sort of anastomosis they have. So let's talk a little bit about the current status of liver transplant in the United States. And this is a nice graph that illustrates the number of transplants that we do, which is roughly about 8,000 transplants a year. And the top line represents the number of people that are waiting, which is roughly about 14,000 people. And so right away you can do the math, and you can see that the number of transplants that we do every year is not equal to the number of people that are needing a transplant. And so what that creates is a gap between the number of people that need a transplant and the number of people that are actually getting a transplant. And this has some very important consequences for people who are on the waiting list. And this is probably, I would say, the number one biggest problem that and challenge that faces liver transplantation and really all organ transplantation, is that there's just not enough livers for all the people that need them. But what it means for an individual patient, at least in our country, is that there's about a 15 to 25% chance that they'll never make it to transplant. That means they'll die from their liver disease before they get to the top of the list. It means that they have to wait a waiting time before they receive a transplant, because the way livers are allocated is based on priority. The sicker you are, the higher you go up on the list. But that, if you think about it, is almost counterintuitive, because you're now operating a very big operation, in fact, on a patient that's critically ill, as opposed to trying to do the operation at a time when they're in a better suited state to be able to tolerate that transplant. So it generally means a more debilitated patient, a more debilitated state, and a longer, more difficult recovery. And the third important thing is that not all of the patients that could benefit from a transplant are actually offered a transplant in this country, because we have 14,000 people in the list, but why make that list 30,000 when you're still only going to be doing 8,000 transplants? And so many patients that could potentially benefit from a transplant are not put on the waiting list because they're either felt to be too old, or the benefit is not felt to be enough, or for whatever reason, they don't go on a waiting list and never get a transplant that could be life-saving for them. So that's why a living donor liver transplant is a good option for these patients, and why it came to be is to try to meet that demand for all the people that need an organ transplant. And what it involves essentially is taking part of a liver from an otherwise healthy donor and transplanting it into the recipient. And there are two very unique properties of the liver that allow us to do this. One is the fact that we have a lot of extra capacity built into the liver. You know, if you're a normal healthy person with a normal healthy liver, you actually need about 25% of your liver to do everything that the liver does. And the other unique ability is that the liver is one of the few organs that we have that'll actually regenerate. And in a very short period of time, it'll grow back to close to full size once you do a major liver resections. And those were the two things that allowed live donor liver transplant to really develop. There are a lot of advantages to a live donor liver transplant over a deceased donor transplant. The most obvious is that if you were going to be in that 25% that was going to die without a transplant, you've got access to a life-saving procedure through a friend or a family member or whatever. But beyond that, it also allows us to decrease waiting time. So now we can do the transplant in someone who's healthier rather than someone who's been on the waiting list for a long period of time, and allow us to transplant these recipients before they become critically ill, turning essentially a emergent operation that's often done in the middle of the night to an elective operation that's done during the daytime when we've had time to make sure that the potential recipient has been optimally fine-tuned to the best possible medical shape that they can be in. There's some other advantages, including financial benefits to doing it, some immunologic advantage. But one important thing to remember is that for every one patient that gets transplanted with a live donor, that frees up an organ for someone who's on the deceased donor list and doesn't have access to a live donor. So it adds to the number of overall organs we have and adds to the number of people that can get transplanted. Now, obviously, that has to be weighed against the disadvantages of a live donor transplant, which is really the main are the risks to the donor. What you're talking about is a major hepatectomy being done in someone who's otherwise healthy, who doesn't need a major hepatectomy. And that's a very unique situation that we create in medicine. The risks to the donor obviously have to be paramount. Now, there are some downsides to the recipient also, because there is a higher incidence of bile duct and vascular complications, or at least the literature suggests there is higher incidence of bile duct and vascular complications, and that's to be expected. Remember, you have smaller vessels to deal with, you have a large cut surface of the liver, all of those things that aren't present in a whole liver. And some amount of decreased hepatic reserve, because it's not the whole liver that you're transplanting here, it's only half the liver or some other quantity. But nonetheless, if you look at it, the results are better with the live donor liver transplant than a deceased donor transplant. This is data from the National Registry in the US. And again, you can see that live donor patients have roughly about a 5 to 10% survival advantage over deceased donor transplants. Now, a lot of that is because these are healthier patients going into their transplant, that they're able to be transplanted in a more timely fashion, which I think really is one of the big advantages of this procedure. And yet, despite all of that, if you look at the United States data, again, this is that graph I'd shown you, if you just concentrate on this part, this is the number of transplants that we do per year. It's roughly about 8,000. But of those, the blue represents the deceased donor transplants, the red represents the live donor transplants. And you can see that live donor transplants really make up a very small percentage of the total number of transplants that are done in the United States, less than 5%, in fact. And there are many reasons for this, but most being that concern about donor risk and the impact on a program from a bad donor complication. But we've here at Pittsburgh, we've felt that that this is a good procedure, and we've tried to offer it as much as possible. This is the volume of our live donor liver transplant program over the last 10 years, and you can see that especially in the last 3-4 years, we've really grown the program. We're doing now roughly almost close to 100 live donor liver transplants a year, and it makes up roughly about 60% of all of the liver transplants that we do at our center, as contrasted with the national average, which is roughly about 5%. But we've really embraced this procedure and think that there's a lot of benefits. We certainly do a fair number compared to many other centers across the United States, as shown here. Now, just to talk a little bit about the procedure, depending on what type of liver or what portion of the liver that you're taking, you have different type of grafts, and you can sort of use what portion of the liver you need depending on the recipient. So for very small recipients, small children and infants, we use the left lateral segment. For older children and teenagers and small adults, we use a left lobe graft. And for most adults, full-size adults, we use the right lobe graft. And it just gives you lots of sort of freedom and flexibility as to, depending on the recipient and the donor, as to which portion that you're going to use. Now, one very crucial part of evaluation for a live donor transplant is the donor evaluation. And essentially, we divide the evaluation up into three main parts. We want to be sure that the donors are medically fit. That means that they're medically healthy. They don't have any underlying major medical problems. That they're psychologically fit. That means that they understand the operation, the risks. They have good support systems, and that this is a voluntary gift. That this is not something that's being coerced on them. That they're not getting financial benefit from it, etc. And then lastly, and the one that obviously I concentrate on, is whether they're surgically fit. And what is surgically fit? Surgically fit really means that do they have a suitable anatomy to allow for this operation to be performed technically. And that's really where we have to rely very closely and work very closely with our radiology colleagues to get a good idea of what the anatomy is of the liver before we go into this. And I would encourage you to think really about, and the way I think about the liver is really in its subparts, as you know, the different 8 components of the liver, the different 8 segments. But really beyond the segments, to think of the liver in terms of inflow and outflow. That's really the most important way to think about it. The inflow being obviously the hepatic artery and the portal vein, the outflow being the hepatic veins and the bile ducts. But if you can maintain good inflow and good outflow to any portion of those segments, then that's a viable segment. And without good inflow or outflow of any of those components, that portion of the liver will not work. And so when you're looking at this, whether it's in the operating room or whether pre-op or even post-op, when you're trying to assess the liver, it's very important to think of the various inflow and outflow components of it. So going back to that previous drawing, if you look at the right lobe graft, you have the right lobe. The inflow is based on the right hepatic artery and the right portal vein. The outflow is based on the right hepatic vein and any cut surface veins, along with the right hepatic duct. Whereas the left lobe graft, the outflow is based on the left hepatic vein and the middle hepatic vein, with the left hepatic duct as the outflow, bile duct outflow, and then the left portal vein and the left hepatic artery for the inflow, and then finally the left lateral segment, very similar. Now, pre-op imaging for the donor, I'm not going to talk a lot about this, but depending on the center that you're at, the main test that you're relying on is either a CT angiogram or an MRI or a combination of the two. And in fact, at our center, we get both a CT angiogram as well as an MRCP to look at the vascular anatomy and the bile duct anatomy. Invasive tests such as actual angiograms or ERCPs are pretty much unnecessary in nowadays with modern imaging and the availability of that. The reason to do any of those is really very few. And I've not done an actual angiogram or ERCP to evaluate a donor in I don't know how many years. But finally, the volumetric study is important because you need to know how much liver you're taking out and whether that's going to be enough for the recipient. And more importantly, how much liver are you leaving behind? And is that enough for the donor? Those are all very important questions that have to be answered actually before you get into the operating room so that you have a pretty good idea. And I won't go through the details of all of this, but imaging has gotten better and better so that we can see all of these things so that we're not getting surprises in the OR, the type of situations where, oh, the imaging didn't show me this, I'm going to have to abort. That type of situation is actually very rare nowadays. especially as we get better and better imaging, and we get the software that can, many centers use various softwares that allow to reconstruct. But as a surgeon, what we like as surgeons are three-dimensional images, and that allows us to translate directly to what we see in the operating room. And so recently we've been trying to look at whether 3D printers can be utilized to help in the pre-op. And this is a 3D model that that one of our radiologists created for me based on the CT scan to try to show the vascular and bile duct anatomy of the donor. And you can see how nice that looks. And you know, this is something that I can take into the operating room, can even sterilize it and have it on the operating field so that we can utilize it. And as the detail on this gets better and better, it's going to become, I think, more and more helpful over time. We're not doing this routinely yet. I've just tried it on a couple of cases just to see, but it may be something that that certainly can give us extra information. Now, I know some of this Amir already covered on yesterday, but I'll just go through some of this because I think you need to know this. The different vascular and the bile duct components. So remember the hepatic arterial anatomy. Now, two things to remember about the hepatic arterial anatomy is that there's an external anatomy and then internal anatomy to the hepatic artery. And what I mean by that is the anatomy of the artery outside of the liver and the anatomy of the liver of the artery inside the liver. And when we're doing whole organ transplants, you know, it's the external anatomy that's most important because we're not really seeing what's going on inside the liver. But when we're doing live donor transplants, you need to know what the internal anatomy is, especially obviously in the donor, because that's going to determine what portions of the liver you can take and not take. And obviously all of the different variations, both to the external as well as to the internal anatomy of that is something that you have to be aware of. You know, you don't have to memorize every single anatomic variation, but you have to know of them so that you know some way, at least as a surgeon, how to deal with them when you encounter them in the OR. So I'll just show you some examples. This is the type of anatomy that we love when we're doing a live donor transplant in a donor, because the left and the right are completely separate. And so if we were doing a right lobe graft, this is actually ideal because the right lobe of the liver is completely supplied by this replaced right hepatic artery from the SMA. And that gives us lots of length that we can take, and we're not worried about damaging supply to the left, which is supplied by this replaced left, and the main artery, which is here, that's supplying segment 4. Now, if we were to take a left lobe graft, this would not be a good anatomy because now you have two small arteries that you have to try to reimplant, especially this vessel is probably quite small. And so that's not a very good anatomy if you're doing a left lobe graft, but it's very good anatomy if you're doing a right lobe graft. Here's a more standard type of anatomy. And just to show you some of the things we look at clinically, so here's the right hepatic artery, and this is a right lobe graft that we were taking, but here's the segment 4 vessel coming off of the proximal right hepatic artery. And we want to try to preserve that because segment 4 is an important portion of the liver that's going to be left behind in the donor. And so therefore our line of transection has to be, and our line of division of the artery has to be right here, taking care to preserve that vessel right here. And here's translated into the operating room. Here's our line of transection right there. We're going to divide the artery, and there's that segment 4 branch coming off right there that we preserved that's going to go to the left lobe of the liver. Now, here's an anatomic variation that you have to, you know, it's good to know about so that you have a plan as to how you're going to deal with it. This was a right lobe graft, and you can see that the right part of the right lobe is partly supplied by the posterior branch, which is here, and the anterior branch, which is coming off of the left hepatic artery that's over here. And that's it right here. You can see here's the main right hepatic artery, and then the anterior sectoral branch, which is coming from over here from the left hepatic artery. So you're going to have two vessels when you take this as a right lobe graft, and we reconstruct that by taking this portion of the artery from a cadaver. So we have a fridge in our operating room where we bank blood vessels from deceased donors, and we keep veins and arteries in there so that we can have them for cases like this, because we take a portion of the internal iliac artery, turn it around like that, and connect it to those two vessels. So now we have a single vessel that we can anastomose in the recipient. Portal vein, again, I won't go through all the different things, but these are some of the variations that are important. Surgically, it's important for us to know, especially this type of variation, which is very common. Probably see it in about 20–30% of patients, where the right anterior and posterior sectoral branches come together almost separately. So you have two separate branches, and again, this is what this looks like in the operating room. This is in the donor, and this is the posterior sectoral portal vein branch, and that's the anterior sectoral portal vein branch, and the left is coming off over here. This is the artery that I've retracted away, and this is once the liver's been divided and the right has been removed. You can see the stump of the two branches where they were taking off, and here's the left portal vein over here. And now this is the situation in the recipient, and on this case, what we've done is, because they were close together, we've just joined the two, and that creates one orifice then that we can anastomose to the recipient portal vein. But if these are separate, what you can do when the two portal veins are separate like that, you can take the bifurcation from the recipient side. So this is the recipient side here. We take that bifurcation, and on the back table, when the liver is still in the cold in a bucket of saline, you connect it here, and now you have a single orifice here that you can then connect back to the recipient. So those are just different methods of reconstruction. There's hundreds different ways to reconstruct these type of things, but it's good to know about all of these variations ahead of time so that you have, as I said, a way to deal with them when you encounter them in the operating room. It's also important to know that there are certain situations that could preclude doing a transplant, especially procuring a certain lobe. So for example, if you were to be procuring the right lobe in this donor, you can see that segment 4 is actually supplied by branches from the right anterior sectoral portal vein, and you have to be willing to either sacrifice those branches or not utilize that donor. Or this type of donor here, where the entire left lobe is supplied by the right portal vein. There's no actual left portal vein. That's a very rare situation, but this would preclude doing at least a right lobe procurement. The bile duct, the hepatic vein, and again, I won't go through all of the different things, but just to point out, what I really want to point out is that the hepatic vein is actually very important when you're looking at a partial graft, because a partial graft is outflow challenged. Because the outflow is not separate between the right and left lobes. It's actually shared to some extent between the right and left lobes. As you know, the right hepatic vein drains the bulk of the right lobe, but a good portion of the right lobe often is drained by the middle hepatic vein, and that can be quite anatomically variable depending on the anatomy of that middle hepatic vein. So knowing the anatomy of the middle hepatic vein is very crucial, and one really good thing is modern imaging gives you very good anatomy of the hepatic vein, very clear, and you can have a very good plan for what to do with the hepatic veins before you get into the operating room. So if you're doing a right lobe graft, you have several options. You can either preserve the middle hepatic vein in the donor. So in this situation, your line of transection is just to the right of the middle hepatic vein. That stays in the donor. And then what you do is then reconstruct these important 5 and 8 segment branches, as that's shown in this schematic diagram here. Or in here, where you have a segment 5 and a segment 8, you can see what we've done here is reconstructed using a piece of cadaver artery. So this is artery that we kept in the fridge, and here's the external, here's the internal, and this is the common iliac artery, and we just connect that on the back table. That allows us to reconstruct both the segment 5 drainage as well as the segment 8 drainage that's over here. Another option is to take the entire middle hepatic vein, is to take it with your graft, take it on the side of the donor, of the donor liver, and not leave it behind in the donor itself. And that's what we've done here. You can see the entire middle hepatic vein is preserved with this graft right here, and then just reconstructed with a short jump graft right over here. Or you can do something that's in the middle, which is that you just take part of the middle hepatic vein and not all of it, And here's a line of transection where we've taken this, and this is especially useful when the middle hepatic vein drains a good portion of the right hepatic lobe, which you see sometimes where it comes, and then the distal portion really goes and drains the bulk of 5 and the bulk of 8. And here's the example of that on the CT, and you can see that the middle hepatic vein starts here and then veers over to this, and the bulk of segment 5 and some portion of segment 8 are being drained by the distal end of this middle hepatic vein. And so our line of transection in this is going to be right along here, and we're going to preserve this branch, which is draining segment 4B in the donor, and this branch, which is draining a bit of segment 4A in the donor, and we're going to divide this and then reconstruct that on the back, and that's what we've done here. The 8 you can see has not been reconstructed in this one. That's this branch right here, or it's actually just clamped for now. And you can see when you do that, that portion of the liver becomes congested because it's not getting good drainage. And that's because in these partial grafts, you're very dependent on these outflow tracts, and that's very important. So how do we decide all of these things? Like, how do we decide, are we going to take the middle hepatic? Are we not going to take the middle hepatic? And some of the things that we're considering on this is that when we take the middle hepatic, it's probably a higher donor risk because you're taking more of the liver. The advantage is that you're getting better graft outflow on the recipient side, and you can use it in more recipients. Or if you don't take it, then the advantage is that there's decreased donor risk, but the disadvantage is that you have probably more outflow problems in the recipient. And it's not that one size fits all is the right answer. We use sort of a selective approach in that we selectively include the middle hepatic vein based on the anatomy. If it's dominant middle hepatic vein that's draining and a small right hepatic vein, then that's the type of situation, if you're doing a right lobe graft, that you want to take the middle hepatic vein. Or if you have a very sick recipient and you want to take a larger liver graft volume that has really good outflow, then that's the type of situation that you'd want to take middle hepatic vein in, as long as you have adequate reserve left behind in the donor. And then lastly, don't forget the other important outflow are these inferior hepatic veins that are there, and sometimes these can be quite sizable, as big as the main right hepatic vein, sometimes even bigger, and you have to know about these so that you can reconstruct them. And here it is in the donor. There's the radiologic image. Here's the intraoperative image. You can see that short hepatic vein draining directly to the cava. That's the donor side, and then this is the recipient side, where we've then re-implanted that directly into the cava. And again, bile duct, I'll just point out that, again, lots of different variations that you have to be aware of. I think MRCP has been helpful. We get fairly good imaging, though I think that that it's still not at least perfect in my mind. I still rely on intraoperative cholangiogram, not only to get a good idea of the anatomy. We have a fairly good idea of that, but intraoperative cholangiogram I find is very helpful for helping me decide exactly where to divide the bile duct, because you want to be absolutely careful that you get the maximum length that you can, but that you don't impinge on the side that's going to be left behind. So here's an example of one where we're going to have 2 ducts, and these are little markers that I put to tell me exactly where I am, so that I know that when I want to divide this duct, I'm going to be dividing it right about, right about here, so that I have maximum length on the right side, but enough of stumps left behind on the left side so that I can oversew those without compromising at all the lumen of the left side. And then finally, volume assessment is very important, as I said, because you have to know how much liver you're taking. Is that enough for the recipient, and how much is going to be left behind, and is that enough for the donor? We use a couple of mathematical formulas to help us, and there are different ones that different centers use, but one easy one is something called the graft weight recipient weight ratio. That's a measurement of the graft weight over the recipient weight, and generally it should be over 0.8%. We know that that's associated with better outcomes, and that the donor should be left with at least 30% of their total liver volume. So those are sort of just some basic goal marks that we use. Now, not all of that is hard and set in stone, because we certainly can use smaller livers in in recipients, sometimes going down quite low on the graft weight recipient weight ratio. And it depends really on how sick the recipient is, how much portal hypertension that they have, and how much liver that they're going to need to really get through. And that's how we decide really whether we're going to take a right lobe graft or a left lobe graft. In someone, we weigh the advantages, disadvantages, and for any one individual, a right lobe may be okay, but for another individual, the left lobe may be okay. All right, so let's move away from the anatomy and just talk a little bit about the outcomes. Now remember, when we talk about outcomes with this type of procedure, you have to know outcomes in both the donors and the recipients. So this is the national data in the US. As of the end of 2019, there had been 7,310 live donor liver transplants that had been done. To date, there have been 6 donor deaths, so this is the most feared complication, obviously, that you have after this procedure. So 6 otherwise healthy individuals that died after donating, and 3 donors that themselves needed a liver transplant. The overall complication rate with this procedure is at about 30%, though many of those complications are minor things. But the major complication rate is at about 10%. This is our own data, where we're roughly at about a complication rate of about 20%, and our mean length of stay in our donors is about 5 days now. Obviously, complications in the donor are very important. You have to try to minimize this as much as possible. This is our own data. We track this very carefully, and I won't go through this in detail, but just to let you know that, this is something that's very important that you need to have a handle on to make sure that it's not above what should be expected. And these are some of the complications that we've seen. Bile leaks and bilomas have been at about 1 to 2% in our center. And our survival outcomes, this is patient and graft survival. Patients alive, livers working. The red represents our live donor patients. The blue represents our deceased donor patients. And you can see that we have roughly about a 5 to 10% survival advantage with our live donor patients versus our deceased donor patients. Now, one very important thing to remember in the post-op care of these patients are the surgical complications. This is whether you're talking about a live donor or a deceased donor. And these are some of the more common surgical complications that we see. Bleeding, thrombosis, and bile duct complications are really the main things that we worry about, whether it's thrombosis of the artery or thrombosis of the portal vein, and biliary complications like leaks and stenosis of the bile duct that can lead to abscesses and cholangitis. And this is often where we're working very closely with our radiology colleagues, because treatment and certainly diagnosis is dependent on that, and often treatment is dependent upon that. This is again our own data looking at some of the technical outcomes and complications that we see. This is our series of live donors on the left and deceased donors on the right, and you can see that these are big operations, and reoperation rates are significant. But our hepatic artery thrombosis rate is roughly about 2–3%. Our portal vein thrombosis rate is roughly about 1 to 2%, and our overall bile duct complications is about between 15 to 20%, which is really quite acceptable. And these are just some of the complications that you can see. This is the patient that presented with cholangitis and had these very dilated ducts. This was a duct-to-duct anastomosis where it had a tight stricture at the anastomosis right here that was treated by stenting with a PTC, you can see there. This is a patient who, this is a donor who presented with fever afterwards, and they had a large biloma on the cut surface, and that was treated by a percutaneous drain that helped resolve this. And this is a patient who presented with diffuse bilomas in all lobes of the liver, and this is someone who developed hepatic artery thrombosis, and often think of that when you have someone that presents with diffuse bile duct problems, because as you know, the bile duct is preferentially supplied by the hepatic artery. Here's just an example of a arterial complication. This is someone who developed a bile leak early, and that was treated conservatively. with a percutaneous drain, but then that unfortunately infected the hepatic arterial anastomosis, and that led to this large pseudoaneurysm right here of the hepatic artery. The anastomosis is somewhere down in there, and then you can see that we fixed that by replacing it with this jump graft, one's to the right and one's to the left over here. So just some of the things that we need, and as we've gotten more comfortable now with especially live donor transplants, we offer it to more and more patients in more and more different type of situations. So for us, really, live donor liver transplant has become the first option that we offer to all of our patients that need a liver transplant, whether they're old, whether they're young, if they have tumors within or outside of criteria, whether they're redos or primary transplants, acute failure or chronic failure. All of those are excellent candidates for liver transplant. And that's just some of the patients that we've done, donors and recipients together, and you can see we've got a real mix. We see all sorts of people that come in, including obviously family members are the ones that are most involved, but friends, co-workers, church members, and often sometimes even total strangers that come in and say, I know you have lots of people on your waiting list that need a liver, please take part of mine, I know it'll regenerate. These are just remarkable individuals and remarkable stories. So I'll stop there, and that'll give us 5-10 minutes for questions.